this is the most confusing of all subjects. While we think that we know about nutrition, we don't know anything. And doctors, unfortunately, know very little. I'm not a nutritionist, I'm a doctor and a scientific researcher, and we have gathered some evidence on nutrition. But if there's anything which is difficult to answer, I'll refer to Shilpa Joshi here, who knows more about nutrition than me. This is the way we go. Most of the middle class is actually on this highway. This is the highway. You know, I once like this, I traveled to 300 kilometers from New Delhi to Mussoorie, and on the way I purposely wanted to sample what is there in those numerous dhabas. Every 1 kilometer there is a dhaba. And if you see, there is nothing else than chips and colas here. This is where I was. And when I ordered the meal, this is a very cheap meal, rupees 10, and this is dal, and this is all butter. And this butter or ghee, as I will illustrate to you, is one of the most injurious of all substances that we consume in India. This is what the dietary practices of the middle class is. And particularly those people who are working and going from one place to another and having meal in between. This is what is most injurious to our pancreatic beta cells and rest of the system. So, a couple of points here. This lecture is aimed at all physicians, is kept extremely simple so that all of you can understand. Key diet-related terms I explained right in the beginning. I will explain to you. Some controversies have been explained in simple and scientific terms, steering away from personal opinions. And as Shilpa knows, and many people know, there are multiple dietitians these days who are so-called celebrity dietitians, giving you WhatsApp messages of all wrong things to eat. Personal opinions. Those are personal opinions. Unfortunately, they are not in touch with scientific reality. There are disclosures. We have done some studies with the help of Hormone Board of California, Herbalife, and my metabolic research team, which is continuously at this research for the last 15 years, and with help of Indian Council of Medical Research, Department of Science and Technology, and Department of Biotechnology. Here is a cartoon. The good news is, it's okay to eat butter. So, you know, earlier there was a slide of butter on cover of Time. Wrongly put there, but anyway. Bad news is not okay to eat any of the things that you put butter on, like bread, or roti, or paratha. This is the potential pathways mediating effects of diet, the risk of diabetes and coronary artery disease. Diet, these are intermediary pathways. Lipid levels, we all know, diet affects lipids, blood pressure, thrombotic tendency, cardiac rhythm, endothelial function, systemic inflammation, hyperglycemia, hyperinsulinemia, oxidative stress, and homocysteine levels. Among them, all are important. These three are particularly important for metabolic syndrome and diabetes, and then all together cause cardiovascular disease. Now, what are macronutrients? What are macronutrients? Carbohydrates. We all know about carbohydrates. Excess is bad. Rice, wheat, maida are the refined carbohydrates. Fats. Now, this is the most controversial, most misunderstood of all macronutrients. Polyunsaturated fat, supposedly good. Fish, nuts, flax seeds. Monounsaturated fat, and one of the first research was monounsaturated fat was done in the University of Texas, where I worked for some time, by my senior from All India Institute of Medical Sciences, Dr. Abhimanyu Garg. 1990s, New England Journal of Medicine paper, monounsaturated fatty acid diet in diabetes, patients of diabetes. Yes. Good. Canola oil, almonds, avocados. Saturated fat. Well, here the controversy lies, and I'll come to that. Bad, I will consider it bad, and in general consider it bad. Butter, cream, ghee, coconut oil, sausages. Trans fat, particularly bad. Biscuits, cakes, donuts, vanaspati, French fries, made in partially hydrogenated vegetable oils. And proteins, most misunderstood, least discussed in any conference. Good. Soya bean, masoor dal, lobia, kabuli chana, etc. So if we are clear about these micronutrients, let's go to the next chapter. Fatty acids. Now, very few people know about fatty acid. How many people here know about fatty acid? Front, I know. Back. See, if you, Shilpa, if you turn your head, there's nobody at the back who raised his hand, his or her hand. So that means it really needs to be understood. Omega-3 fatty acid, which is the polyunsaturated fatty acid. This is the most talked about and most written about. Eicosapentaenoic acid and docosahexaenoic acid. These are long chain polyunsaturated fatty acid. Long chain 20, 22. These are only obtained from fish. Fish are the only source. There is no other source. So I don't eat fish. Many of us don't eat fish. We are devoid of this. Then we go on to take alpha linoleic acid, which is carbon atom 18. So this is a shorter chain fatty acid, and they are available in some plant sources, nuts, seeds, etc. These are converted subsequently into eicosapentaenoic acid and docosahexaenoic acid. So a clear-cut source of EPA and D are the fish. Now omega-6 fatty acid, these are also polyunsaturated fatty acids. Remember, polyunsaturated fatty acids are good. Linoleic acid, which is 18,3, is converted to gamma-linolenic acid to arachidonic. We know about arachidonic acid. We have heard about this in the MBBS curricula. These are found in corn oil, sunflower oil, soybean, as well as poultry eggs. These are supposed to be good. Now, oleic acid, MUFA. We wrote about this earlier. MUFA is good. And this is the oleic acid is the main MUFA, which is omega-9. So omega-3 here, omega-6 here, omega-9 here. Long chain PUFAs, shorter chain PUFAs. 18:1 cis-9. Canola oil, sunflower oil, and almonds. They are good sources of monoinsaturated. I'll come to sources again. And palmitic acid, which is a saturated fat. Now, here is the main problem. Palmitic acid. 616, as the carbon atom is going down, we are encountering bad fats here. Bad fats in lower carbon atoms. High in palmolene and dairy ghee, propensity to cause atherosclerosis and increase in metastatic potential. Not bad at all. Not good at all. All bad here. So if we have understood this particular table, let's go forward and say that Indian diets are deficient in what? Low fiber, and these are all documented. These are some of our studies have been done in the last 15 years. Low intake of monounsaturated fatty acid, high intake of trans fatty acid, imbalanced omega-6, omega-3 ratio, which has been less talked about, and low protein. And they had multiple consequences, which we see every day. We have been talking about the last 2 days. But particularly important is this, which causes increased propensity for coronary artery disease. But if we balance this, then we'll have better cholesterol, less inflammation, less insulin resistance, and less coronary artery disease. So diet is the key. Diet is the key as far as we are concerned. These are some of the things which you will encounter in your mails and your WhatsApps. Eating more fat butter does no harm. This is the current thing going on. Ghee should be taken daily, builds body. This is our mothers, handed down by generation. Have to feed ghee to the child who's looking normal weight, he's weak. We have to eat, more ghee here. Coconut oil is good for heart. Zero cholesterol oils are the best. If we stop dairy product, we lose weight, decrease blood sugar, and improve heart. Stopping wheat, this is another fad which is going on. Gluten-free diet is good. Nuts produce heat in the body and increase weight. Now, I will not be talking about all these because of lack of time, but some of these will be touched. This is the key slide. This is the key slide and must be understood by you. This is not my slide. This is from American Heart Association, but one of the best slides explaining if we replace saturated fat with any other, what happens to coronary artery disease? What happens to the coronary artery disease? So replace saturated fat with other types of fat or carbohydrate. For example, if we are taking 10% saturated fat in the diet and replace it with trans fat, then our coronary artery disease will go up. But if we replace with MUFA, we'll benefit. Replace with PUFA, further benefit. But carbohydrate from refined, see this, saturated fat is taken off, carbohydrate is given, more coronary artery disease. And carbohydrate from whole grains, less coronary arteries. So carbohydrate are two types, refined and whole grains. Now here, look at this. Walnuts, soya beans, sesame, peanuts, safflower, rice bran oil, salmon, PUFAs. And wheat, barley, jaw, oats, millets, jowar. These are complex carbohydrates. Remember, these have been used by our ancestors for so long and have been forgotten by us. Now, these are sources of monounsaturated fatty acid. And the top are the oils, which is canola oil, olive oil, and some of the high oleic acid oil. Then there are nuts, whole lot of nuts. Almonds are available, cashews, etc. Peanut, pistachio. Pistachio has one of the highest monounsaturated fat, 10.1. But the highest actually is in macadamia nut, which is not often available in India. And then some other, avocado. And in the series which will appear in Lancet Diabetes and Endocrinology, we write that the consumption of pistachio, almond nut, has been associated with multiple metabolic benefit in Asian Indians with fatty liver and multiple risk factors, and we'll come to that. Now the problem is the current controversies about the fat, and that's why the butter on the cover of Time. This is pure study, which includes India, investigator Rajiv Gupta, Mohan, and others, led by Salim Yusuf, and which actually interprets contrary to what we have been thinking. High carbohydrate intake was associated with higher risk of total mortality, whereas total fat, so carbohydrate is understood. We have seen that. Higher carbohydrate is a problem. But total fat and individual types of fat are related to lower total mortality, lower. Going against the current view. Total fat and type of fat are not associated with cardiovascular disease, myocardial infarction, cardiovascular disease mortality, and surprisingly, saturated fat, there is inverse association with the stroke. More you take saturated fat, lesser the stroke. Not very well understood by any of us, and actually there have been a number of letters to the Lancet on this issue, including our letter, and which we say, in conclusion, we applaud the Pure investigators for providing extensive data for discussion, but we think alternative strategies and guidelines, especially in countries such as India, is premature. We are not taking this on the face value. But let me show you one particular recent study to convince you that the high fat is not good. A single high-fat meal provokes pathological erythrocyte remodeling and increases myeloperoxidase levels. This is the isocaloric meal and RBC morphology. Everybody can understand RBC morphology? And you can see here that on high-fat meal from here onwards, microcytosis within 4 hours of giving a high-fat meal, acanthocytosis, echinocytosis, foamy macromonophages, and lipid-liquid monocytes, all within 4 hours, totally dysregulation of RBC morphology, and all this can precipitate heart attack in person who is already prone to it. And the myeloperoxidase level in a high-fat meal can cause plaque rupture. So for me, fat is never good. I don't alter my opinion after the Pure study. So let's see. some of the Indian study. Supplementation with edible nuts. How nut supplementation helps? Nuts contain high amount of MUFA. We have already seen that. And several other beneficial elements. What is the Indian context? Snacks consumed by Indians are often healthy. We know that. Bhujia, whatever, kachori and things like that. Traditionally, Indians consider nuts as a healthy snack, but do not consume enough. This is our case control study on pistachio nuts in people with metabolic syndrome, published in Nutrition. Remember, one pistachio has 4 calories, one handful, 30 gram or 1 ounce has 120 calories. One handful is enough for you per day. In this particular study, 20% energy from pistachios were used. And these are the 2 diets, pistachio plus the exercise and the controlled diet, 180 days study, which shows significant reduction in waist circumference, subcutaneous fat. We used MRI to quantify subcutaneous fat, adiponectin level, fasting glucose decrease, and number of other lipids, HSCRP decrease. Look at this. Single point intervention as far as nutrient is concerned using pistachio nut in people who are high risk for developing diabetes and coronary disease. Second, in patients with diabetes, what is the ideal snack? We use almonds. One almond has 7 calories, one handful, which is 30 grams, 23 almond is 160 calories. In this study, 20% of energy was replaced with almond, and again, this had scientific design of the study and showed there is no weight gain with this almond within the diet prescribed for diabetics. Marginal weight loss, significant decrease in the waist circumference and waist height ratio, significant improvement in HbA1c without changing any drug, anything else, and lipids and HSCRP. So these are good. Pistachios are good. Almonds are good. And recent study by Mohan's group on cashew nut. 9 calories, one cashew nut, 30 grams per day was used in the study, one handful, which is 18 cashew nut, 3 months in patient with type 2. Very interestingly, increase HDL. We never see increased HDL in many studies. And decreased blood pressure. Blood pressure, we never saw any response in blood pressure in our study. It's decreased blood pressure. Edible oils. How change of edible oil helps? Different edible oils have different amount of saturated fat, MUFA, PUFA, and trans fatty acid. What is the Indian context? Indians are used to cooking in some oils like mustard, vanaspati, palmolene, ghee, and coconut oil. And in this particular diabetes and Lancet paper, we write that major problem in the diet, which is high in carbohydrate load and unhealthy oils. This is a key slide. This is a key slide showing different types of fatty acid composition of different oils. Now, the yellow is MUFA. And then saturated fatty acid. Look at the saturated fatty acid in coconut oil. And then this is alpha linoleic acid, which is converted to omega-3 fatty acid. Very little in some oil and some more in some oil. And the rest is linoleic, omega-6. Now look at this. Almost 82% saturated fat in coconut oil. Highest PUFA seen in safflower oil. Remember, PUFA is good. Highest omega-3 is seen in the flaxseed oil, which is often not used for cooking. And then highest MUFA is seen in olive oil, and then MUFA is also very good in canola oil and mustard oil. Mustard oil is good. Look at mustard oil. Omega-3, MUFA, omega-6. Hardly any saturated fat. So a comparative study of olive, canola and oils low in MUFA in patients with non-alcoholic fatty liver disease with multiple risk factors. And this is the same design, 3-arm design, 180 days of study. And we saw liver size decreasing. When we used olive oil and canola oil, liver size decreased, OTPT decreased, transaminase decreased. Apart from that, there was benefit on waist circumference, insulin, fasting blood glucose, and lipids. So these oils are good. These also, except canola oil consumption causes memory synaptial problem and neuropathology in triple transgenic mouse model in Alzheimer's disease. After that, we have stopped using canola oil. I don't know what happens to the brain in canola oil, but this is a scientific report, one of the highly cited journals. Coconut oil. How many are using coconut oil? Not many. I thought many people will be using.
Yeah, you are in Pune, sir.
Okay. 82% saturated fat, half lauric acid, 12 carbon atom, medium chain triglyceride. Some people say medium chain triglyceride is good. It causes ketone body generation. And the rest is myristic palmitic acid. Palmitic acid is also there. Remember, palm oil, palmitic acid, not good. A recent systematic review showed, in 7 controlled trials showed that coconut oil compared with oils high in MUFA or PUFA, coconut oil raised LDL in all 6 out of 7 studies. And remember, we are only concerned about LDL, nothing else. That is the more cardiotoxic. And they say that there is no difference between coconut oil and butter and beef fat and palm oil, almost similar. So we are not going to use coconut oil too frequently. Ghee, how many people are using ghee? Oh, that's great. 40% of the population is using ghee. But today you may have look at this differently. 62% saturated fat, 27% palmitic. Can you believe this? 27%? Nothing else has that much of. MUFA is the only thing which is good here, and 4% trans fatty acid. Now, this is traditional. My mother is very, very attached to ghee. You must take a little bit of ghee every day. Mahabharat Kauravas were born from pots of ghee. But that's not good. Ghee is also used in bhang in order to heat the cannabis to cause debug. So many other bad things about ghee. But if you look, we don't go away by emotions, we go by science. Look at the scientific literature, only 34 scientific articles, and most of them are small articles, 5, 10, 15, 20. Human, only 2 case control studies, only 2, not in India. Not in India. One in UK, one in Pakistan. Now look at this. Nish Chaturvedi's studies. Nish Chaturvedi is very, very distinguished investigator from UK. The ghee versus non-ghee cooking increases heart attack risk by 3.9, hazard ratio is 3.9, ahead of smoking, ahead of diabetes. But this was a UK study, and there is a problem here because I don't know whether they use vanaspati, which is a partially hydrogenated vegetable oil, and ghee or both. Vanaspati has definite, because trans fatty acid, definite cardiotoxic effect. So we go to the second study, which is a Pakistani study, very well done study. And there you see, they have categorized butter and ghee 1 to 2 times, 3 to 5 times, 6 times weekly, and found that for daily users of ghee, heart disease risk is up to 19 times. 19 times. They use inter-heart study dietary questionnaire. Very good dietary instrument that they used. We believe them. But then, if somebody is still not convinced, let's go to the next slide. These people from Malaysia used the ultrastructure of aorta in spontaneously hypertensive rats. It is a high-risk situation. It changes very fast. Control oil, palm oil, soybean oil, and ghee. Look at the endothelium, what is happening ghee in 4 months' time. Now let's look at this a little bit more. macrophages are coming in, elastin is going up, collagen fibers are all everywhere and infiltrating smooth muscle cells. Would you like to have that? If you don't, then please restrict your. And there are study, we say that it is possibly more athogenic than coconut oil. Let's go further and say cinnamon, how cinnamon helps. We have used cinnamon in our cooking for centuries. Some studies have shown the insulin sensitizing effect of cinnamon. And what is the Indian context? Cinnamon has been used as traditional spice in India and Sri Lanka. We use cinnamon in a double-blind, randomized controlled trial. And this is the type of trial, very double-blind. One capsule of cinnamon to one person and similar placebo capsule to another person, and found that the blood glucose decreased, postprandial A1C decreased, and all components of metabolic syndrome benefit, and HDL, like Mohan study, HDL increased. 34% reduction in people with metabolic syndrome. This is a study on the people with metabolic syndrome. So cinnamon, approximately 3 grams a day, which is half teaspoonful per day, will help. What about the protein? How high protein intake helps? Previous studies have shown that high protein, non-vegetarian diet help in weight loss. What is the Indian context? Indian have less intake of protein. And that we are sarcopenic, our muscles are markedly low, and vegetarian diet provide low quality protein. We are all affected by this, all in this room. Many people are sarcopenic in this room. Like shown in this particular study, where they looked at whites, blacks and South Asians and used grip strength to measure sarcopenia. Look at this. In males, 79% in South Asian and UK. Here it will be more. Our sarcopenic, 81% of the female, almost all. And this is used by Jamar dynamometer. And the sarcopenia, that's why I was talking in the morning, sarcopenia alone, irrespective of height, weight, body fat, physical activities, smoking, anything adjusted, attributes to high risk of diabetes in Indian population. Muscle alone. We have to improve our muscles. And this particular study showed that if we give high protein to mouse, 15% to 50%, the immediate there is decrease in the food intake, and which remains so during the period of feeding. So protein has effect on appetite through multiple mechanisms. It increases thermogenesis, so it decreases weight, increases satiety by production of cholecystokinin, PYY, GLP-1. GLP-1 is induced by high protein, and which actually affect nucleus tractus solitarius and arcuate nucleus. Right here, they're dealing with satiety and motivation to eat by nucleus accumbens, which is mesolimbic reward system, acting in multiple pathways. We looked at this in multiple studies, and this is one study, which is a meal replacement study, and this is another ICMR funded study where protein intake was increased to double. In both the studies, first study I am describing, a 90-day study, high protein diet was the standard diet. Protein was increased from 15% to 29%, and so carbs also decreased. And it showed multiple body fat decrease, blood pressure, sugar, insulin, and liver enzymes decreased markedly. Has effect on the liver. So all abnormalities that we have are ameliorated by this protein. And finally, in last couple of slides, heating and frying. Does heating, frying, cooking affects ingredient? We hypothesize that such practices may be causing high tendency for Indians for diabetes and heart disease, and we published this hypothesis in Nutrition along with Smita and Raj Bhopal from UK. And what is the Indian context? Most Indian cookings, and all of us, heating, कढ़ाई में तेल डाला और उसमें हीट करा, फिर वही कढ़ाई रात को यूज़ करी, फिर वो कढ़ाई कल यूज़ करी, oil wahi par pada raha. This is what we do at home, and multiple times, 1,000 times is used outside the home. And we have current advisory of WHO on trans fatty acid and saturated fat. 1% trans fatty acid and 10% saturated fat is the limit. So how does heating cause trans fatty acid? This is in Lucknow, my home city, and this guy, I once watched him for 2 hours just to see how many times he gives heats and reheats and gives this samosas and other things to people. Almost 2 hours time, he heated 60 times, same oil. This is our study, which is published in Food Chemistry. Whatever oil, and this guy is using this oil. Because vanaspati, long shelf life, can be stored anywhere. No problems in storing. High trans fatty acid going higher and higher with each heating. But if you're using soybean, like in this hotel, maybe soybean, and reheating increases the trans fatty acid. Almost 200% trans fatty acid. And look at this. Chips, the baseline trans fatty acid and saturated fat. Potato chips, high saturated fat, high trans fatty acid. This is the trans fatty limit by WHO. And look at this, that samosa is as bad as French fries. All have high trans fatty acid and high saturated fat. So last 3 slides. What is the summary of all this? We increase MUFA in our diet by increasing soybean, soy product, nuts, almond, pistachio, walnuts. We increase omega-3 fatty acid in the diet, grilled and baked fish. If you are a vegetarian, then rajma, black gram, lobia, baked beans, flaxseed. Chia seeds also. Increase fruits and vegetables, which is a universal advisory, 4 to 5 helpings per day, preferably raw. Increase fiber by including whole wheat atta. Do not exclude atta from your diet by those people who say gluten-free diet is good. Porridge, oats, maize, jowar, whole pulses and grams. Olive oil, mustard oil, rice bran oil, soybean oil. Avoid frying and high heat. Even if you are at loss, some oil is wasted, please waste it. Discard oil after cooking. Increase protein, those who are vegetarian, chana, lobia, these have high amount of good proteins, Masoor dal, tofu, cheese, eggs are good. 1 egg a day with yellow, no problems. Cinnamon and stock, ghee, coconut oil, vanaspati, palm oil, trans fatty acid containing food and sugar containing beverages. I've come to the last slide based on the article which will appear in British Medical Journal. Neeta Frohi from UK is leading that article. General Principle for Diet in Diabetes, and this is the current evidence at this point of time as far as diabetes is concerned. Weight management is the cornerstone. Key area of controversy is low carbohydrate nutrition as diet of choice. Quality aspect of carbohydrates such as refined versus whole grain sources are important. We have already told you so, and should not get lost in the debate on quantity. In individuals with T2D, emphasis should be on promoting vegetables, healthy protein food, nuts, yogurt I have not talked about, and on avoiding processed food I have not talked about, refined grains, processed meat not talked about, and sugar sweetened beverages. No single diet applies universally, and dietary advice should be individually tailored, taking into account personal, cultural and social factors. Thank you, sir, for giving me this opportunity. Thanks.